Well, I am going to jump in because we already have 4 or 5 questions. And I'm going to start with this first one because this came up in a program yesterday about managing diarrhea. We know that diarrhea is a significant side effect of many different kinds of many different classes of medications, and looking for some tips on ways of managing both diarrhea and constipation. And why don't we start with you, Dr. Dizon?
Sure. As you've stated, it is a very common symptom, particularly with these the newer drugs that we're using, especially I'm thinking of the HER2 directed agents. It is a very common complaint that people have. And what's always been so interesting, and it's been coming out through more active conversations with the patient and patient advocate communities, that the way we think of diarrhea as clinicians doesn't really reflect how the lived experiences of someone. Kind of doesn't matter if you're only going 1 to 4 times a day, which would be, in the way we quote grade things for clinical trials, for example, it would be a minor concern rather than requiring hydration, which would be the ones that we're very, very alarmed about. I think the movement is to understand that any diarrhea is really not pleasant and can really impact quality of life and certainly the experience of someone who is benefiting from treatment. And I think we really need to come together in understanding the toxicities as experienced by the people who are living with it need to be reflected by the way we talk about toxicities in a clinical context. Having said that, I think the biggest things to understand about diarrhea is to really try to address bowel motility proactively rather than trying to chase it once it's started. So what this means for me is if I know I'm starting a drug where the risk of diarrhea is high, it's one of the first things that we will talk about, modulation of diet. And it's very difficult if one is going from diarrhea to constipation to modulate diet, because as I'm sure the people on this webinar understand, it's very easy to flip where you're having watery stools, you take Imodium, and then all of a sudden you haven't gone to the bathroom in 3 to 5 days. So this is where the individualized program really needs to come in. But for starters, if it's something that I know has a very significant risk of diarrhea, we will talk about diarrheal management from the get-go. In fact, if I get a sense that someone might have diarrhea on a new drug, based on maybe prior experiences, I'll say, why don't you go ahead and start on some Imodium at night so that we can get on top of this. But, that's really important. Your diet changes, I think, as you go ahead with cancer therapies. And I think your ability to tolerate certain foods is different. So it's really an important aspect of management is to understand what your body is able to tolerate as well. Sometimes I'll ask people to try to go without gluten, for example, or maybe stay away from lactose and see if that helps things, just sort of as a dietary management. But it brings up another thing as well. Nutrition, really important. Getting a nutritionist involved in your care early as part of your multidisciplinary team is really important. So those are my initial thoughts.
Thanks. And as a follow-up to that, Dr. Dizon, yesterday, a couple of people in the chat had mentioned cholesterol for diarrhea and wanted to know more about that and if it's a safe way of managing it.
Yeah, so I don't use it often. Actually, I don't prescribe cholesterol. It can be very useful. We know that for people who say have gallbladder issues or biliary tract problems or even a pancreas deficiency, cholesterol oftentimes is used. It's not one of the standard drugs that I will go to, though.
Okay, thank you. And Evelyn, was there anything that you wanted to add to that in terms of the tips that you often give patients around managing diarrhea?
Yeah, I did want to add that it's extremely important to have close communication with your team. Sometimes our patients suffer in silence, and that diarrhea can be so severe that it can lead to dehydration and hospital admissions and other concerns. So, the importance of really ensuring that if you have an issue, call your team, discuss with them what's going on, because sometimes we can review good tips. Like Dr. Dizon mentioned, diet is extremely important for some of our patients. And constipation is a horrendous side effect as well. When you have it, it just affects how you feel, what you want to eat, what you want to do. So both those issues require really close monitoring and discussion with the team. And then I would say also, good care of the perianal area. It can become very uncomfortable with the diarrhea. So managing that, sometimes using, rather than toilet paper, using some of the wipes can be important. And sometimes just moisturizing the anal area with something that can lubricate the area to make it less uncomfortable may be helpful as well. So look at your diet, look at what's helping and what isn't helping, and then continue communication with your team throughout.
Thank you. Thanks for those practical tips. So I'm seeing a number of different questions that are focusing on the side effects of anti-estrogen therapy. So I'm going to ask a couple of those. We have one message here about dry skin and some suggestions that you might have for managing dry skin that's a result of anti-estrogen therapies.
Yeah, I'm happy to start. That's actually a very common concern as well. I always, if those of you who've ever seen me speak on the aromatase inhibitors, for example, know that it's to me, it's the Dr. Jekyll and Mr. Hyde drug. It's so effective in the management of breast cancer, either preventing a recurrence for those who are just treated, just diagnosed, but also to help control disease and in fact induce remissions for people with metastatic disease. It's a very important class of agents for us who treat breast cancer. However, when I put my sexual health hat on, it's also one of the worst drugs, I think, for people to try to tolerate. In addition to the sexual side effects, which are well known, and I wish more docs would talk about, it does cause those issues of dry skin, changes in your hair texture, in addition to the menopausal side effects it causes. When we think about how to control dry skin, the things that we were taught about when we were kids is really important. The type of soaps you use, make sure it's a moisturizing one, not one that dries out your skin. Again, your skin might have changed as you've been treated for breast cancer. And certainly your skin is very different from what it was when you were first diagnosed. So that's really important. Using, a nice moisturizer frequently on almost daily basis, also really important. And doing your best to manage the sensation is what I would say is the way I would advise you to do it. Because dry skin, even though you might think it looks really bad, it's a very unpleasant sensation too. So we want to control the symptoms that are associated with it.
Thanks, Dr. Dizon. And then another question that we have also associated with estrogen blockers is about joint pain. We know this is really, really common with the aromatase inhibitors. And Evelyn, I'm wondering if you could speak to some ways that you advise people to manage joint pain with those.
Yeah, that certainly is a side effect that can sometimes cause some of our patients to decide to stop therapy. So first of all, trying to speak with the team when that happens, because sometimes switching between the aromatase inhibitors can make a difference in some of our patients, and then discussing what therapies can help. I usually have patients try glucosamine with chondroitin, which can help some of the patients, not everyone, but definitely something to try. And there could be other therapies over the counter. Tylenol sometimes can help if you're able to take it, or ibuprofen, some of the NSAIDs can be helpful. But just really making sure that if something's not working, you discuss with the team so we can figure out what else may be of help. So there's other things you can try as well. Some of the topical medications for joint pain can be helpful for some people. So it's a matter of finding what works for you. Heat therapy, cold therapy. Everyone is different. Some things help some people, some things help others. It's a matter of finding what works best for you.
And thank you for that. And are there situations where, Dr. Dizon, for example, you might switch someone from one aromatase inhibitor to another if it was getting to be too painful?
Yeah, just to expand on what Evelyn said about how to manage, this does have, the name for this syndrome is the aromatase inhibitor musculoskeletal syndrome because it's so common. So, and it's something that we've been doing trials on and how to manage it. So things that, paradoxically can help. We now know that if you're more active, you can actually reduce the musculoskeletal symptoms. It's so common when people on an AI come in to see me, they seem so debilitated that they cannot move due to the arthralgias, due to the pain. But I thought what was so important to understand is that in a randomized trial where they compared exercise with NSAIDs, just like Evelyn said, to NSAIDs alone, that exercise really is very helpful in reducing the scores. So again, it's been part of my practice when I start someone on an AI to mention, try to stay as active as you can, being healthy, adopting a healthy lifestyle is a really important thing when you have metastatic disease and you have to have and you're looking at a continued treatment with AI therapy. So that helps. There's some data about acupuncture. If someone can't even fathom taking a pill to manage the side effects of a pill, then you can try acupuncture. There is some data that suggests that works, and there's some data that says acupuncture can also help for the menopausal symptoms as well. And then duloxetine is the other drug, which in a randomized trial showed acutely better control of pain compared to placebo. Although in the trial I'm thinking of, the placebo helped some people as well. But as you went into third month around there, the scores sort of came back together. So again, whether or not it's a worthwhile relief is really something that you and your doctor need to help determine. Is it worthwhile to try a drug where on average there was short-term control but maybe not long-term benefits? I have had some people say it's worth a shot if it's going to help me stay on this drug. But for Evelyn, what she said is exactly my approach. If someone is almost debilitated from the AI therapy to the point that it's affecting their lives, they can't work because of it, they can't do the things they need to do in their lives because of it, I will stop it. I will stop it for 2 weeks, and then we either try it again or we move directly into another drug in its class, because I agree with Evelyn, and I've seen it myself. People who say don't tolerate anastrozole will be able to tolerate letrozole, and we can't understand why there's that idiosyncratic response as well as tolerability to these drugs.
Okay. Thanks for answering that. So really important to have an open communication with your healthcare team and be able to tell them what is going on so that they can evaluate what works best for you. So we have a couple of questions about managing hot flashes, particularly those that happen overnight when you're trying to sleep. They wake you up, you're completely drenched. What suggestions do you have for lessening those or helping people to be able to manage them?
Yeah, a shout out to my colleague Kelly Shanahan, who unfortunately is not able to bring her up on the stage, but her dual experience as a gynecologist and someone living with this disease would be very helpful. What I will say is that there are non-hormonal interventions that this community has helped us really identify. The one that most recently seems to be pretty effective for the hot flashes, and I'm really interested in doing a clinical trial of it, is cherry extract. Some people actually swear by this, that cherry extract can really help with the hot flashes and the menopausal symptoms. There are antidepressants. If it's really problematic, antidepressants can be tried. Oral hormone therapy is contraindicated if you have breast cancer, and there was a trial called Habits that looked at the safety of oral hormone therapy. But just like the larger trial called Women's Health Initiative, the conclusion was hormone therapy is bad. But when you try to get into the specifics of who was it bad for, most of the risks were borne by women with hormone-positive breast cancer with a uterus. Because if you have a uterus, you have to take combined hormone therapy. And even in the study of women without breast cancer, it was the combined hormone therapy that was associated with an increased risk of breast cancer. Whether or not estrogen only for people without a uterus, for example, and metastatic breast cancer, whether that's safe is really an open question, in my opinion. Remember that there's actual studies that suggest high doses of estrogen can actually be used to treat metastatic breast cancer. So the way that our oncology community of breast specialists have sort of honed down and said all hormone therapy is contraindicated, it's really a global statement that I'm not necessarily in agreement with. But until we have the data that parses that out and says, for this population with hormone-positive disease, this formulation of oral therapy appears safe, we're taking a chance. And so even without the data, I still think it's not a good idea to do it.
Thank you for sharing that. I want to address something that's coming up in the questions. Actually, Kelly commented while you were talking about how frustrating it can be when you're already taking medications to get a script for another medication to have to manage the side effects of the cancer treatment. And a couple of other people have similar comments and are saying, basically asking, how can you as a person getting treatment advocate to treat the root of side effects before just getting another script for something? What are some things to maybe integrate palliative care all along the way? And so I'm wondering if each of you could speak to that.
I'll start. I would say that there are definitely a lot of practical tips that can be helpful for some of the women who are going through these hot flashes. It's an entirely uncomfortable side effect that can affect your everyday life. For women who are going through them at night, it can affect the sleep cycle, which lessens fatigue, which leads to people just feeling overall sometimes mentally depressed and going through other issues emotionally. So it is really important to try to figure out what are some of the tips that can help with this side effect. I talk to our patients about first trying to figure out what are some of the practical things and understanding what causes the hot flashes to worsen. So we know that for some women, caffeine can worsen the hot flashes, alcohol can worsen the hot flashes, very sugary foods can worsen the hot flashes. So the first thing is looking at what are making the hot flashes worse and seeing if those can be decreased in the diet and in everyday life. We also know that there are studies showing that exercise, like Dr. Dizon had mentioned, that it helps with some other symptoms, can also help with hot flashes. And when we think about exercise, it doesn't mean you need to run a marathon, but becoming more physically active, whether it's walking around your neighborhood, whether it's taking extra steps and monitoring the extra steps that you're taking. But exercise is another tool that can actually help with hot flashes and help with the fatigue as well. And then other practical tips, maintaining yourself well hydrated, especially with cool drinks, can be helpful. just layering your clothes. Sometimes you just take off the second layer, cool down, and then when it's improved, you can put back your layer, because then sometimes you can go from the hot flash to the cold flashes, which can also be very frustrating. And then for some people, they keep a cool fan around. They're just looking at what are the tips. Using cotton clothes rather than some of these other synthetic clothes can make them worse sometimes. So looking at what works for you and then putting those tips to work if you're trying to avoid using medications.
Thanks,
Yeah.
Evelyn. Dr. Dizon, did you have something you wanted to add there?
No, I was just going to endorse everything that Evelyn said. The things we talk about for women who have not had breast cancer are very relevant for people with breast cancer on endocrine therapies. So, lifestyle modifications are really important. I'm just going to go back to the cherry extract. MJ Borelli, as well as Sammy Mansfield, have corrected me. It's not the cherry juice that you get in the grocery store and just drink. It's actually tart cherry extract, which apparently, I've not tried it, is very tart. It can be even to the point of being bitter, but it's tart cherry extract, and I'd love to do a trial on that. Having said that, I think because of the symptoms that can come with metastatic disease, I am a very strong advocate for a supportive care component into everyone's treatment team. And that's what we call it here at Brown. And we modeled that after the MD Anderson experience. As much as we, like Evelyn and I in the medical community, want everyone to embrace this concept of palliative care as separate from hospice, I think all of us agree there's a connotation when you mention palliative care, that someone is terminal or that they're looking at hospice. And I think I spend much of my time discussing palliative care, explaining that. And even now, 5-10 years later, I'm still explaining it, because the person in the room hearing that term hasn't had the benefit of looking at it from the research perspective, reading the opinion pieces, reading everything my society has written, and how Evelyn and I stand on how important this is. They're just hearing it for the first time, and it's a very difficult concept for people to embrace, especially if you've just been told you had metastatic disease and now I want you to have palliative care. What we've done is adopted as supportive care, because really that's it. Supportive care that involves issues that are traditionally in the survivorship realm, healthy lifestyles, exactly like we're talking about, nutrition and diet, heart health. These are things that are important, even if you have metastatic disease, or, although you have metastatic disease, it's not all about existential crises, being one with you spiritually, looking at controlling, your, where and how and you die and what's said at your funeral and all these things in hospice. So supportive care is that concept that we're going to walk this path with you while you're healthy and well and doing everything you want. And if it gets worse, we will transition as your goals transition. So again, bringing that back, Janine, to what you were talking about, I do think it's really important.
Thank you. Yeah, we know that this is a real frustration for a lot of people who want to access this type of supportive care, but have difficulty sometimes getting it in the metastatic setting. So really appreciate both of your input on ways to talk about it in the healthcare setting in particular, so that people can get what they need. So I'm going to pivot a little bit to some different kinds of side effects. And I think we will probably come back and talk a little bit more about some of the anti-estrogen therapies. But someone is asking about the itchiness that is sometimes associated with HER2 targeting therapies, and what recommendations you might have for managing that.
Mm-hmm. Okay, I can start. I think the itchiness is also called pruritus. Sometimes is a manifestation of dry skin or dry symptoms. I do have people who their integument, the integrity of the skin is fine, but they do have that itching. Honestly, I have a very low threshold to get specialty help or involvement for those folks. Sometimes what we will recommend, if they can't get in to see a dermatologist, for example, right away, the things that help with, environmentally cause itching can sometimes help here. So, sometimes Benadryl cream, taking a bath, moisturizing the skin, all of things can really help. There are some drugs that can help with itching as well. I try not to go right to medical therapies because, again, people are already doing so much in terms of the medical treatments that I'm not a fan of putting a drug on top of a drug on top of a drug to help, deal with the side effects. So sometimes creams are very helpful, moisturizers. If it's very serious, sometimes I will do a trial of a low-dose steroid cream to see if that will help. Benadryl can also help with the histaminergic properties that might be causing it.
Thank you. And as a follow-up to that, someone is saying that that itchiness is sometimes seen as a form of neuropathy, and can it be treated differently if it's thought about as neuropathy, or how would you look at it from that perspective?
Yeah, I mean, I've actually that's an interesting concept of looking at the itching as a neuropathic concern. Oftentimes, it to me it sounds almost like an inflammatory histaminergic effect almost at the skin. But you're correct, and quite frankly, there's not exactly the golden bullet that's going to help stop that. So certainly, if it might be a manifestation of a neural injury, for example, then it does make sense to try things that can help or that we hope can help with other neuropathic concerns. So this is where gabapentin or Neurontin might come in as an option for you.
Great, thank you. And Evelyn, is there anything you'd like to add to that in terms of management of neuropathy?
Yeah, no, I think that neuropathy is one of those frustrating side effects and symptoms that unfortunately we don't have great drugs for. So the goal is to try to prevent it as much as you can or minimize it once you do have it. One of the things that I always stress to my patients is the importance of letting us know as soon as you have it and if there's any worsening, so that it does not become a chronic issue for our patients. Sometimes patients, don't want to decrease the dose of their therapy, or they're afraid that that might affect their treatment, and they don't want to talk about, how the neuropathy is getting worse. So that, again, that importance of communicating very closely with your team about this side effect is critical for the management and for prevention of it getting worse. And then, we have drugs to treat the pain. We don't have great drugs to treat the numbness and to treat some of the other effects of the side effects. So, really important to have close communication.
Thanks, Evelyn. So our next question is about how to reduce and deal with mouth sores. Dr. Dizon, would you please speak to that?
Yeah, I mean, mouth sores, again, particularly for drugs like capecitabine, really, really difficult for a lot of people. What and this might be the recurring theme for Evelyn and I, we really need to try to prepare you for the side effects that, in our experience, have been the most troubling for people who have walked this path before you. So it is one of the things I talk about with certain drugs where I know it is a problem that's been brought to my attention. And I do that because I want you to tell me as soon as possible if it's something that does help. We have things, it's called magic mouthwash, for example. It's a Benadryl base cream, base solution that, someone can swish and swallow that can help with the symptoms of a mouth sore. But we can also prescribe, antifungals, for example, that you can take to sort of lessen the time. And it does seem to help with mouth sores. But so much of that is for me to navigate with you by maybe reducing dose or maybe increasing the time between treatments so that, the worst thing that I've ever seen happen is someone with some very mild mouth sores who restarts the next cycle. Because unless that's completely or fully healing, by the time I start a new cycle. This will the onset of new mouth sores will make the ones that are already present so much worse.
Yeah, and then for me, I would say that again, prevention is so critical. One of the things I discuss with my patients is the fact that there are great tools that have shown that uh, are very good at preventing or decreasing the mouth sores, which is either making sure that you rinse your mouth with saltwater gargles or baking soda gargles. It can make a huge difference. And my recommendation is that you do it after every meal and before bedtime. And people can see a reduction and also a prevention of the mouth sores using those simple tools.
Thanks,
I
Evelyn.
should, I should clarify because Nancy is correct in terms of the magic mouthwash. Depending on the formulation, it may not be safe to swallow. The one thing that we will sometimes try is nystatin. That one is a swish and swallow, especially if someone is complaining of pain with, say, their throat and swallowing as well.
Thanks for clarifying that, Dr. Dizon. And since we were talking about capecitabine, there's a specific question about that drug. And talking about how to manage hand-foot syndrome that can be associated with it.
Yeah, that's a huge concern. And I will say with capecitabine, it's not one of my favorite drugs to treat metastatic breast cancer because I am very mindful of the side effects that drug can cause. Really important to protect yourself if you're on capecitabine. The worst side effects I've ever seen on that drug is for someone who was not aware they should stay out of direct sunlight. And I have seen people come in with almost third-degree burns from the sun exposure. So again, really being very careful about staying out of the sun is important on capecitabine. And then again, the same things will apply. Sometimes I will ask, folks, because I've been told they help by other people, just like in this wonderful chat that's going, there's some great suggestions from the community for each other. But sometimes I will have people do some cool mitts and cool socks, sometimes just having your feet, setting your feet in cool tepid water is really good. Bag balm has been the one thing that has been remained constant since I was a fellow at Sloan Kettering, using bag balm to moisturize your skin frequently and on a very routine basis has been one of the things that's been helpful. And then if the side effects are present, that needs to prompt my reaction, which might be to delay.
Thank you. The next question is also specific to a particular drug, Piqray, and wonders if there is a preferred way to manage hyperglycemia that's a drug-specific side effect of that particular medication.
Yeah, I think it's one of those drugs that has revolutionized the care of metastatic breast cancer. I have taken, I don't know, Evelyn, what your practice is. If I'm even contemplating Piqray, I will get an A1C, even if someone is not known to be a diabetic. I'll get a baseline A1C because of the risk of hyperglycemia. There are these anecdotes within our community. I think Evelyn's probably heard them too, of people starting Piqray and going into hyperglycemic complications. So this is an issue that where I will not start it unless the A1C is below 7.5, and then I will have blood work checked frequently. If you're on that drug, following healthy nutritional advice would be useful as well. Not going so far as doing a diabetic diet, but certainly being cognizant of the sugar intake you're doing. And then it's up to us really to make sure we're looking at your labs frequently.
Evelyn, was there anything you wanted to add to that?
No, completely agree with that. The importance of that hemoglobin A1C ahead of time and then just really close monitoring afterwards because it can become a very significant issue for some of our patients.
Okay, thank you. So I have one other medication-specific question about palbociclib. And this person is saying that as they get toward the end of their cycle, they experience incontinence and a strong odor. And just wonder if that's something that you've seen in your practice and whether you have any suggestions around managing that.
I think that's a really interesting toxicity I have not heard about, but there are things I've seen with patients on CDK4/6 inhibitors that are not included in the label. One of the most worrisome ones that I have seen is pulmonary toxicities to the CDK4/6 inhibitors, where we ruled everything out, and the last thing standing was her CDK4/6 inhibitor. We actually stopped it, and she regained her pulmonary function, but it looked, for all intents and purposes, like she was headed towards scarring of her lung from it. Again, nothing that's reported in the literature. This might be one of those things, but it's really important that we try to rule out what else is going on. It might be a really good place for a urogynecologist to get involved in your care. If this is someone who's had children, for example, it's not uncommon for the pelvic floor muscles to be weaker, and that oftentimes will manifest with urinary incontinence. And certainly being on this drug, having that pre-existing health condition based on anatomy for someone who's had kids, for example, can be the thing that is responsible for what is being perceived as a drug-induced side effect.
Thanks, Dr. Dizon. Actually, since we started talking a little bit about the sexual organs, there's a number of questions about sexual health. And one person is saying it can be an awkward conversation, but intimacy is so important to me. What advice do the two of you have about dealing with dryness in the vaginal area?
So I would say for me, that's a conversation that I often have with our patients, because it is, a very important part of your partner communication and just that partner relationship. The vaginal health for some women can be severely affect them, leading to pain, leading to just loss of function of that relationship. One of the things that I always try to recommend is using a good lubricant, either a water-based lubricant. I actually love 100% coconut oil. There's some literature that shows that it can also be an antifungal. But with any other oils, either olive oil or coconut oil, you can't use it if there's a condom being used, because it can affect the condom. So having a great lubricant, considering some of the vaginal moisturizers like Replens can help. And if those first steps are not helping, then I'm sure Dr. Dizon can also discuss some of the other medications like Vagifem that we can use. And again, it's that communication and making sure that if the first steps doesn't work, that you discuss what other steps may be helpful.
Yeah, I did a webinar with Dr. Kelly Shanahan, and we talked about the sexual health and how important it is for everyone, men and women with metastatic disease or quote without evidence of disease at all. I think the issue is it's double complicated for people with metastatic breast cancer, because oncologists already are reluctant or hesitant to talk about sexual health. And, I think it needs to be something that we mention with every single chemotherapeutic drug that we administer, because if anything, the menopausal side effects are not related solely just to the anti-estrogens, and it can change people's lives. So if you're going to mention hot flashes, you've got to mention what's going to happen or could happen in the vaginal vault, and how it might affect intimacy. Not everybody's going to want to explore that topic, and certainly many people may not want to explore that topic at that time. But I think the importance of us just bringing it up when we're doing a new drug, for example, is that it does open that door, so that when that woman is really struggling or ready to talk about intimacy, that they know that door was open. And then, I think most of us, when we seek care, we hold on to these moments as opportunities to explore in the future. If that hasn't been offered to you and you're having issues with intimacy, it can be very hard to talk to your doc about something that he or she has said has never brought up, or maybe even has said something in passing, and like, we don't talk about sex here, for example, right? In which case, I would suggest that going to folks within your team, your NP, your RN, your infusion nurse, your social worker, and say, I don't know who to bring this up to, but it's something that I do need to talk about. And that can be the opening that folks can have so that you can get help. Because, it's one thing just to, provide a history or to tell me what's going on. I have done nothing to help you if I say, well, that's too bad, and walk out the room, right? You're bringing it up because you want to know what can be done about it, not what you can be done about it, but what can be done about it for me. The other thing that's a problem that all of you in the metastatic breast cancer community, along with folks who advocate for sexual health for everybody, is facing is that the diagnosis of metastatic breast cancer somehow makes sexual health irrelevant. So I had an experience in somewhere I worked where a very talented breast oncologist, I would say one of the top 10 in our area, in our field, came up to me at a meeting and was like, hey, you do sexual health, right? Yes. Who can I send someone with metastatic breast cancer to? And I was just like, well, you could send them to me. I was like, oh, I didn't know you treated people with metastatic disease. And when I thought about it, the people I see with metastatic breast cancer don't come to me because our clinical team have sent them. They're coming to me because they found I exist. They are self-referring. And I think that is a really irresponsible onus to put on someone in whom we are saying we're going to take care of your whole person as you live forward with metastatic breast cancer, to have them sort of navigate this very intimate area by themselves is just not appropriate. And so I have taken to saying that when I talk about metastatic disease to my colleagues as well, because Evelyn is completely correct. There are interventions that are available. Someone here asked about Mona Lisa Touch, so let me just mention that really quickly. Mona Lisa Touch is laser therapy. It's vaginal laser therapy to help stimulate collagen formation in the vaginal vault and increase moisture. There has been no randomized studies. I've been very interested in doing this for a long time. Can't get funded, not a lot of support to do it, and you have to wonder what would be the sham control for such a thing. But vaginal laser therapy has very limited data that suggests for people who undergo the 3 treatments compared to historical controls, it does help with vaginal comfort, vaginal dryness, and painful sex compared to, again, to historical controls. The big caveat is that A, it takes 3 procedures, B, it's not often covered by insurance, and C, there's a warning that was placed by the FDA on Mona Lisa and vaginal laser therapies in general because it can burn the mucosa. So I got asked these questions quite a bit, maybe 4 years ago. It seems to have tempered the enthusiasm when the FDA came out with this advice about vaginal laser therapy for sexual dysfunction.
Thanks for sharing that. We do get a number of questions about that procedure. So I know folks hear about it and are interested in knowing about it. Another area where I'm seeing a lot of questions and a lot of confusion is around the use of vaginal estrogens.
Mm-hmm.
Could you speak to the safety or non-safety of those in people with hormone receptor positive metastatic breast cancer, and really with other subtypes of metastatic breast cancer as well.
Sure, sure. Evelyn did mention, vaginal hormone therapy, and I think it is a very reasonable option no matter what your breast cancer subtype is. There have been multiple groups from the American College of Obstetrics and Gynecology, and then the panel that I participated on was Cancer Care Ontario's clinical guideline on sexual health after cancer for both men and women. And, we've looked at the data of safety of vaginal estrogen preparations, and the top line conclusions are it's never been linked to increased breast cancer events. We're talking vaginal therapy now. That the older studies that looked at vaginal therapy, which showed, by the way, for patients on an aromatase inhibitor, you can detect a measurable bump in serum estrogen levels on vaginal estrogen. Oftentimes they use a higher dose than are in practice today. And even those studies that showed there was a bump in the estrogen levels, there was no associated clinical relevance to those findings. So they didn't attach them to increased local recurrence rates or increased metastatic disease rates. And it was not associated at all with any survival outcomes that this audience would be really, really interested in. So the guidance from ASCO, the Canadians, the American College is very similar. Try non-hormonal preparations first, just like Evelyn was saying. If they do not work or they're not satisfactory for whatever reason, discuss vaginal estrogen therapy, the data, which is it's safe in terms of clinical outcomes. There are not a lot of great data to confirm that, but even though there are these slight bumps in estrogen levels with older estrogen preparations for people on an AI, this does not seem to be clinically of importance. So if you would like to do it, I am fine with you doing it, and I will prescribe it for you. But it's informed conversations leading to informed decisions and choice in someone who has not had a benefit to non-hormonal preparations.
Great. Thanks for answering that. So I'm going to move to a couple other questions because we're getting close to the end of our time together. We have someone who is interested in understanding recommendations to manage bone thinning or osteopenia that's caused by cancer medications.
So, very interestingly, we put together a clinic at MD Anderson Cooper because many of our patients with their breast cancer treatment, whether we threw them into an early menopause or whatever the case have been, deal with osteopenia and osteoporosis due to the treatments we gave them, due to aging, due to their menopausal status. And for us, the main recommendation is first looking at what are the contributors to that bone thinning, besides the treatment, besides menopausal status. And it could be diet, again, could be very important, getting the appropriate amount of calcium and vitamin D, whether in the food or in the supplements that you're taking, are extremely important. And the other thing that, again, is a lifestyle modification that can make a big difference is exercise, physical activity that puts weight on your bones, whether it's walking, whether it's light weights, whether it's biking, anything that's putting weight on the bones is really important for bone health. So once we look at those, once we can make changes in lifestyle, caffeine can sometimes worsen. If there's a lot of caffeine intake can worsen the bone health. So looking at those simple changes can make a big difference. And then sometimes we do need to add medications to treat the bone thinning as well. And I'll let Dr. Dizon talk about some of the bisphosphonates and other therapies we can utilize.
Yeah, thanks, Evelyn. And I completely agree in terms of just, proactively monitoring, looking at other things that might be affecting bone health encouraging a healthy lifestyle, encouraging exercise, and encouraging weight bearing. Certainly, all of those can help people on a go forward basis. I think one of the more important things to know is that baseline is so important. And if then the studies of, say, aromatase inhibitors, which we know can affect skeletal health, it really mattered what you look like at baseline. So if you come into an aromatase inhibitor, for example, with normal bone density, the chances you're going to break your hip on an AI with a normal bone density at the start is pretty darn low. The people who got into trouble were those people who had osteoporosis, so really thin bones when they started that treatment. Those are who I worry about a lot, and those are the people that I will initiate bisphosphonates for. So if you have osteoporosis, I will send you to a dentist, because we will make sure your teeth are done, and if there's any dental work that needs to be done, that gets done before we start a bisphosphonate. Because one of the dreaded side effects we talk about, again, with everybody, is the risk of that your jaw will undergo some kind of surgical therapy and will not heal. Osteonecrosis of the jaw, very well described complication from bisphosphonate therapy. Typically, we will start zoledronic acid, though. People get cleared by their dentist. They have osteoporosis, and I'm starting an AI. We'll actually put them on a bisphosphonate. There's a different drug called denosumab that can be used to shorter infusion time, but it's much more expensive. So I typically will not use that. And then, I think part of that is the follow-up, with bone densities. We do it at least every other year. But for someone who has, say, borderline osteoporosis, or, is really struggling with, say, arthralgias, which are not the same as the bone density changes that Evelyn was just talking about, but it is possible to monitor bone density on an annual basis, because there's a code that my endocrinologist told me about. Long-term use of an AI is an indication for more frequent bone density evaluations. And our endocrinologist will actually use annual bone densities if someone is on an AI therapy. And that's something I only learned through our wellness program, which Sammy knows well, but Sammy Mansfield, who's, shout out to her for helping us, it's the Wellness, Lifestyles, and Survivorship program. Those three components is where we have this multidisciplinary medical team, including an endocrinologist on there. And I learned so much from them.
Thanks so much, Dr. Dizon. So we only have a couple more minutes, and I want to try and squeeze in this one question. Someone is asking about the effect on blood counts from treatment, probably white blood cell counts, and how to maneuver through life during the pandemic with COVID, when you may be having the side effect of treatments that makes you immune compromised. And I'm curious if you and Evelyn could comment on the advice that you're giving your community.
Yeah, it's very confusing. I don't think Evelyn and I have done a great job in terms of our our chemotherapy or our oncology community and sort of messaging. And the messaging around COVID has been so super complicated and messy that I think, this community and others just find it very, very confusing. So the neutropenia that chemotherapy causes does not hinder the efficacy of the vaccine. Neutropenia and lowering the white cell counts of the neutrophils, which is what chemotherapy typically will do, will make you more prone to bacterial infections. And oftentimes it's your own body's defenses breaking down, so your normal bacteria can get into your bloodstream and cause problems. So that has nothing to do with the immune response that the vaccines actually induce, which doesn't rely on your neutrophils. It relies on an intact T cell system to actually recognize those epitopes, create those memory T cells, and can activate when you get COVID or if you're exposed to the virus. So viral infections and the risk of viral infections is very different from the risk of bacterial infections. Chemotherapy causes an increased risk of your bacterial infections, but as long as you're not lymphopenic from chemotherapy, and you can actually look at that with your absolute lymphocyte count, the ALC, you should be able to respond to these vaccines. Now, having said all of that, people who have had more complications from COVID-19 include people on chemotherapy as well as immunotherapy. So everything I just said is overly simplified. Okay, everything I just said. So I think what that means, though, is that you got to talk to your docs. It's like, will I be able to respond to this treatment? Should I get vaccinated? My answer is always going to be yes. Should I get a booster? My answer is always going to be yes. And you can even state, if I do get sick, should I take these new medications to prevent myself from being hospitalized? You, by the mere nature of having your cancer and being on treatment, are at that quote high risk of getting a complicated COVID infection, of being hospitalized. You should be able to get Paxlovid, which is that 5-day oral therapy that needs to be taken as soon as you're symptomatic and if you test positive. So Paxlovid can prevent the virus from shedding at an earlier rate and is over 90% effective in keeping you out of the hospital. The one side effect I've heard, just so everybody knows, it can cause the most horrific taste in your mouth. So that's the one thing I've heard. And you need good kidney function to take that drug.
Thanks, Dr. Dizon. Evelyn, anything you want to add to that?
No, the only thing I would add, completely agree with Dr. Dizon, is the importance of hand washing. You can't do that enough, whether your counts are low or whether your counts are normal. So just ensuring that when you're out in the community, you're washing your hands, trying not to touch your face, and just having normal, practice of good hygiene is extremely helpful.
Thank you.
So I did want to, Sharon Anderson just put in this chat that her oncologist took her off a vaginal insert because of estrogen. I would actually point, so this is where we have to encourage self-advocacy among our community and also be there to support each other. There's really great data that someone with triple positive breast cancer, their outcomes are not going to be dependent on whether or not they have a vaginal estrogen preparation that's being used. And we're talking about a quality of life benefit and intimacy between a couple. So if that's something that is important to a dyad, to you and your partner, don't feel like you have to give up your sexuality because cancer has taken so much from you already. It doesn't need to take that away too.
Thanks so much for adding that, Dr. Dizon. And I think one message I get from listening to both you and Evelyn is that your healthcare provider should be treating the whole person, your sexual needs, your emotional and mental health needs, your physical needs. And so we do have to wrap up, but if you want to just each of you say one thing very quickly, what is the top message that you would want our community to get from this program about what they should be discussing around side effects with their healthcare team? And I'll start with you, Evelyn, and then we'll end with Dr. Dizon.
Yes, I would say that no one knows your body as well as you. So it's really important that if you have an issue, if you have a concern, don't put it aside, discuss it. Make sure that you're heard. Sometimes, like Dr. Dizon was speaking about earlier, maybe it's not the medical oncologist, but some other member of the team that will be able to support you. Just speak up and make sure that whatever your concerns are, they are addressed.
Thanks, Evelyn. Dr. Dizon?
There are so many friends on this call. I just want to shout out to everyone that knows me via social media or through TikTok. Follow me on TikTok at Dr. Donis Dizon. But for everyone that has interacted with me, it's great to see you on here. I wish we were doing this in person. And I just have two things to say. A, you are still survivors, even if you are living with metastatic breast cancer. And that term, unfortunately, has been sort of, it was made so much more complicated because the IOM report really suggested, we meet the needs of people who were treated for cancer and are fine. by making sure they get the flu vaccine, making sure their heart health is being checked, and all of these things, that it became synonymous with being cured, survivor cured. That is not the case. Survivorship started when you were diagnosed, and you didn't cease to be a survivor when you were diagnosed with metastatic breast cancer. I think it is a loaded term, and some people just don't identify with it. So I'm here to tell you it's fine if you don't want to be called a survivor. If you adopt another term, if you want to be called a thriver or a Metzer, whatever the term is that you identify with, that is you. That is your term. Just like my pronouns are my pronouns. Okay. But the reason this exists, Evelyn and I sort of still work within this context of survivorship and really trying to reframe survivorship from diagnosis, is because this is where the research lies. We have to come around to a term so that we can provide the funding for the fundamental questions that we hope will inform the better ways to treat you while you live through this disease.